Let's start off with the beginning where if you have a patient with metastatic prostate cancer, hormone sensitive, how do you all approach, and how do you obviously they get the workup, biopsy, then comes the imaging studies, and nowadays we do PSMA PET scans. So in your practice, what is your experience has been? Is there any difficulty in getting PSMA PET scans? How is the nuclear medicine and the radiologist, availability of the scans? How soon that can be done, or any challenges and experiences that you can share?
I can start on new diagnosis. I mean, I'm sure we all have different variation, but what I generally use is the NCCN or the AUA guidelines to look at if it's unfavorable intermediate risk or higher, roughly Gleason 8 or PSA greater than 20. Then I look at initial staging, but for low-risk disease, we don't always stage. And then we go through all the localized treatment options. If there is signs of metastatic disease, then we have to go down that pathway, which is a little more complicated now.
Okay. Have you had any difficulty in obtaining PSMA PET scan?
We have some payers that just don't pay it. There's a couple private payers. There's a couple private payers that will cover it, but they require conventional imaging first, so we'll have to get a bone scan and a CT or an MRI, and then if that's equivocal, then they'll cover the PET. Medicaid in the state of Georgia universally doesn't cover it. So most of the Medicare plans do. So it's just sometimes the privates, we have to kind of do step therapy or step imaging before we can get it approved.
And how about the availability of those scans? Can they get it on timely fashion? And how about the...
Our PET scan center is definitely backed up. So there's a prior auth for a lot of these Medicare replacements or managed care Medicare plans. Those are slow. And then once we get the approval, there is a backlog. So it might take, it's not horrible. Our MRI centers actually are backed up further, but it might take between 2 and 6 weeks sometimes.
Yeah, so there are definitely, it looks like some challenges, in terms of the imaging studies that we typically would do, for this type of patients. So, okay. And then, once you have a patient that has a diagnosis, then, what would you do next step? How do you collaborate with other specialties and especially medical oncologists? So if you can say, how your practice is.
So I think we would have to break it down into, at least I would break it down into 2 different patients. There's the patient who walks in with first time seeing a urologist, their PSA is 500, they haven't been to a doctor in years, and that they most likely have full-blown metastatic disease. But then there's the patient who's been through stuff. They've had surgery, radiation, HIFU, whatever, and now their PSAs are starting to go up. They've never seen hormones like Eligard, Kemsevi, or Govix. They haven't seen anything like that, and their PSAs are going up. And of those guys, you can even break them down into the ones who are lost to follow-up or the ones who are religiously in your office every 6 months, 3 months, a year, and you're just watching their PSA creep. And so for the guys who are walking in and we've never seen them before, PSAs of 500 and plus or whatever, that one, it's going to be a challenge taking care of them because they haven't been to a doctor in years. Yes. So for them, it's always important to get a tissue diagnosis, even though you know what's going on. For them, we would start them on, once we get a tissue diagnosis, we would start them on some kind of ADT, like Lupron, Eligard, Kemsevi, Orgovix, Firmagon, whatever is available. And then once you go down that path, that's when I would get your CAT scan, bone scan, PSMA scan. Sometimes I go right to PSMA scan, depending on the payer. Sometimes I will actually, if I have a patient in front of me that I know has been doing well in life and they can pay out of pocket, I will encourage them to just pay out of pocket. And then once we have all that information, that's when I start getting on board with the medical oncologist, talking to them about the role of chemotherapy. When you have the person who has been through therapy and they're starting to rise, my understanding is once the PSA hits 0.2, that opens up our opportunity for a PET scan, the PSMA scan. But even within then, sometimes we want MRIs, sometimes we want just bone scan. Like, I think you have to kind of feel out that individual.
Understood, yeah. So I think, Dr. Greenstein, you really, make a great point about the tissue diagnosis. So, for those patients, that we feel that they have an advanced, metastatic prostate cancer, and, we can make a diagnosis of that based on the radiographic findings and an elevated PSA. But I think in today's day and age, the tissue diagnosis is important, not only for diagnosis, but also for molecular analysis. So, it's very important, and we do that in our practice as well. They can still start their, ADT, for example, and afterwards we will do a prostate biopsy just to get the tissue that we will need for molecular analysis. So we typically don't need that for diagnostic purpose, but we need that for molecular analysis. So I think that's a very important point.